So it's amazing. We are at week 5. We're almost halfway through this course, and it's going by quick. You've already had your first exam. So again, I've gotten some messages and I'm making up a schedule to get you all in so that I can see you. I haven't answered them all yet, but we'll get you in. And I'll work around your times because I know your time is precious. 3 courses, families working. I know you guys are really, burning candles at both ends of the wick, and I know that. So I'll work with you. So
That's
week
the only
five,
teacher that thinks that.
week 5, we did the first quiz. Next week we're going to have a quiz on cardiac. So I did send out, somebody had sent me a message, thank you for letting me know that you couldn't open the matching. So I've put it in the chat box so that you can download it and you can have it. You should be able to get it from there, okay? And that's why it came up there. I had students say it didn't work. So thank you so much, appreciate it. Again, communication gets results, doesn't it? So again, another thing to tell you about that. There is a CJ Sims coming up, and again, your discussion question number 4. So we've been really good with CJ Sims. They're all caught up now, so good job. And just try to do your best at them. You just need above a 90 to get 100%. So you can do them until you get there. Anyway, this week, rough week, cardiac, respiratory. As I said, you've got your matching. I've actually re-updated the Kahoots and updated the PowerPoint. I think I added more pictures in the PowerPoint and a couple little things that I saw lacking. So you guys get the first ones to get to work with it. So here we go. Again, this information probably is one of the most important on exams. They always like to hit cardiac and respiratory, especially respiratory, don't they? It seems that's one of those topics that they want you to know well. So if you're not understanding anything, please just stop me. Well, respiratory system in children. Remember, it also includes upper airway, your nose, oral pharynx, because all of that mucus drips down into the respiratory. So I took a picture and I showed you it's from nose all the way down into the lungs. Another way to depict it is to tell you there's upper and there's lower, right? We know the upper is all that mucus that goes up into the ears. It's all part of respiratory problems. And then we know the lower ones could be pleural effusions or like pneumonias. Most upper respiratory infections are viruses. Rarely are upper respiratory infections caused by a bacteria. They can, of course, if you get to the point of mycoplasma, pneumonias, yes, those are bacterial, but usually they're viruses. So how do we treat a virus? Antipyretics, fluids, and rest. That's all you do, not an antibiotic. Now, we're going to go into RSV a little bit more. RSV for me and you, as you can see the pictures, is really not much. It's that runny nose, cough, and just don't feel good. Now, infants, they can't breathe. And you can see this apnea. And they're poor feeding. What do we know about infants? Nutrition, 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 right? So if they're sick, have a fever, they got mucus in their airways, they can't suck, swallow, and breathe. They don't feel like it. They don't eat. They're not getting nutrition. They're not getting liquids. And then the fever keeps there. And then they have periods of apnea because it's all blocked up. So RSV in infants is a big deal. In infants is that from ages 0 to 1 year old. As they get a little bit older, it's again not as bad. It's just they can blow their noses or they can get it out a little bit better, but it's the infants that it's the big deal. Now, again, talking about immunity and how does the body fight it? Well, viruses, you're going to be getting these your whole life. And your body is going to be building up antibodies against it. So many times you can't get that virus again. But viruses, they're always, changing. They're always morphing, as I call it. So you're always going to be hit with something new. Now, the younger you are, the more dangerous they are. And here's another reason. Infants less than 3 months old, mom's antibodies hopefully will be helping you. I mean, if you're breastfeeding, you're getting those antibodies right there because mom probably has that little cold too, right? But for that ages 3 to 6 months, mom's stuff has gone away. The baby hasn't really had a chance to build up any their own antibodies. So this is when they get sick. This is when you see your sicker children. Children less than 3 months who are sick, we take extremely seriously, especially below 6 weeks. In the ER, there's different charts according to severity of needs. And a red chart is one of the highest priorities. So that would be an infant that's 6 weeks or less with a fever. Because there's nothing, the body has nothing, no defenses hardly, only the little bit that mommy gave. Now, as we get older, what do? We become toddlers, preschool, we change toys, we swap spit, as I say, in the daycares, right? We're exchanging germs like crazy. Actually, we're helping each other. They're sick every week, driving the parents nuts, but they're building up antibodies. So by the time they get to in school, now they're school age, their immunity is a lot better. And now it's more of the bacterial infections. And as we just said going along, increased immunity with the age because they've been exposed. Their body is like, okay, I've had that already. Okay, you're not going to do it to me again, right? Those antibodies are there to say no. Now, one of the things about children, everything's short and open. And you know that if there's mucus, it's going to find that crevice where it can get into easy, right? It's the areas of least resistance. You go from full up, oh, there's an empty little something there. Well, let me put the mucus in there to get it somewhere. Because many younger kids can't blow their nose. So it just keeps filling up and filling up, right? And we know it goes right into their ears. Why? Short, open, little tubes, back of their throat, straight up into the ears. And that's why there's a lot of ear infections in children. Now, what do you see with children? Children are all the same, but you will always see a child who starts with a fever. All of a sudden, they're not playing, they're not eating, and they're not drinking. That's number one. They get a fever and they don't want to move. Well, then it gets into the vomiting, the diarrhea, and the cough and whatnot. But usually your first little sign and symptom is that sitting in the corner and not eating, not playing like they normally do. So we know symptoms could be acute pain, that fever, and the rest of the stuff. And then, of course, all of that mucus, upper airway, because they really can't get rid of it, especially the younger children. So in respiratory, and we have all this mucus, upper respiratory, whichever, bacterial, viral, what is our goal in management? Well, we want a child to breathe easier. We want them to be able to rest, and we want them to make sure that they know how to use hand washing their hands, using a tissue, putting tissues in the proper place so that they're not spreading it to the rest of the family. And the one thing about children, they're sick, but you give them acetaminophen or you give them ibuprofen. About 20 minutes, 30 minutes later, they're up and running around and drinking like they're not sick. Now, why do we medicate children? Not because they're going to have seizures or whatever because of fever. We're going to be able to bring down that temperature so that they feel better. They're going to drink and eat because liquids are so important during fevers, giving that. And then they'll be taken, be out running and they don't feel as bad. And parents feel better when the kid's up and running. So otitis media, as I said, it's all that mucus goes up into the ears. So how do we treat it? Well, the oral pharyngeal area is full of staph. If you take a little culture of your nose, there's staph there. I mean, and many people have MRSA and don't even know it, but it's staph. So ear infections, that mucus has gone into the ear. We treat it as a bacterial infection, and that's why. So First of all, what do? Well, child comes in complaining of ear pain. You're going to manage that pain with acetaminophen or ibuprofen. That's always priority. Get that pain down. And we're going to be starting an antibiotic. Usually they start with something simple like an amoxicillin. And amoxicillin takes care of staph, usually goes away. Now, as nurses, you're going to make sure that that parent knows to take the entire dose of medicine because chronic ear infections can cause hearing loss. We learned that last week, that if you don't take care of it, that hearing is going to be diminished. And then you get my age and then the volume has to go up on everything, right? So you got to be careful with ear infections and children that they take all of it, okay? You know, otitis media, they also say, can be caused by smoking in the environment too. It was one of the things that they say. Also, having them sit up, especially infants after feeding, so it doesn't go back into the ears. Okay, all of that milk and whatnot. So these are a couple little things, little tricks for these children and infants mostly. Now, you've heard about mono, right? Infectious mononucleosis. And we call it the kissing disease, right? Because it's spread through, mucus. Now, mononucleosis is a virus. So we treat it like a virus. It is the Epstein-Barr virus. It makes you tired and weak and you can't move. Symptoms. What do these children show up as? They show up flu-like with a sore throat. That's what they look like. You might even see the lymph nodes in their neck and their arms, getting, enlarged. Because remember, when they're sick, you see lymph nodes, not when they're healthy. You don't see them at all. So let me give you a scenario of what happens because it's very hard to diagnose. So you bring your child to the doctor, they have a sore throat. The doctor takes a swab, does a flu test, does a strep test, negative, 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 negative. So you're sent home, treat it like a virus. Tylenol, ibuprofen, liquids, and rest. Well, the kid's not getting any better. They go to urgent care. Or they go to the ER, or they go back to the doctor. So now it's like 5 days later. So they come in and they're still the throat. We're still seeing swollen lymph nodes. We're going to do a blood test. Well, we're going to do a CBC. We're looking for WBCs. Is it bacterial, right? And then we're going to do something called a monospot test. And it's just in the blood. And it will show us if it's positive, which you have mono, and negative, of course, you don't have it. So how do we treat mononucleosis? Well, mononucleosis seems like a nothing disease. I had a little boy, 9 years old, came in with his daddy into the ER, and he had been through 5 days of going to the doctors and still felt horrible. We did the CBC, white count was normal. We did a monospot test, it was positive. And we told him it's a virus, acetaminophen, ibuprofen, force the fluids, and mostly important is rest and protect that abdomen. No contact sports. If you have brothers and sisters that like to wrestle on the ground at home, I had 6 brothers. It happened all the time. So you can't let it. Why? The spleen, the liver, or both will get enlarged. And it's like a balloon ready to pop. This little boy, the doctor told the father and the child. I also reinforced, protect that abdomen, no sports. You've got to go back to your pediatrician in 3 weeks to see if he'll clear you to go back to PE even in school. And we sent him home. 1 week later, I get a trauma alert. I'm the primary trauma nurse. So whatever comes in, I'm in charge. So we get this call, kid fell off of an ATV. They're in full CPR on the way in. It was this boy. He was on an ATV, fell off, his abdomen fell down on a rock, his spleen burst, and he arrived dead on arrival. This is mononucleosis. So very important that we do teach our children as nurses not to go out and, do these things for the amount of time that we said, because it can burst, and it is that easy. It's like a balloon, it just pops. And I'll never forget that little boy. Now, bronchitis is the trachea and the bronchus, and it gets inflamed. And there's no mucus, it's just inflamed. This is the one that you cough, cough, cough all night long and you can't sleep. You're like, I just want to sleep, and you can't. This is bronchitis. So it's a dry, hacking cough, non-productive, and it's worse at night. So how do we treat it? Well, we're going to be given that acetaminophen, ibuprofen, just for discomfort. Maybe not a fever, not necessarily. You try to give them humidity, and then, of course, some sort of cough suppressant, cough medicine, or, lozenges, whatever. And that's the treatment. Many times you will see physicians with bronchitis order a Z-Pak. Really common practice for this. Now, another upper respiratory is croup. This is the seal barking. This is a loud, loud cough. And when you hear it, you know it. And what happens is the oropharynx airway starts to swell up. Okay, so even right there by your epiglottis, it's swelling. So you're going to start to hear, and it's important, inspiratory stridor. You can't get air in. You can blow it out easy, but because it's all swollen up here in the upper airway, you can't get it out. All right, so inspiratory. Now, croup, if you leave it continued and don't treat it, which is just steroids, stop the inflammation, okay, it can turn into epiglottitis. Now, we're going to go into that in a second. Now, another name for croup is laryngotracheal bronchitis. Again, this is all upper, right? And again, most of them are your viruses. Usually you'll see croup, you've had a cold recently, and it's inflamed in there, and there's swelling, and you'll hear that inspiratory stridor. And because you're pulling, you're going to see substernal retractions. And you're going to hear it from across a very loud, busy ER. Oh, that kid's got croup. That's how pronounced that is. And as I said, if we don't treat it, it's going to turn into acute epiglottitis. Well, all right. What is epiglottitis? Well, what's an epiglottis? That's the thing that covers your trachea when you swallow. So the liquid food goes down your esophagus and not into your lungs. It's a leaf-like structure, they call it. So it gets swollen. It's over your trachea. Guess what? Air can't get in. So it is an emergency. So what would you see? All right, epiglottis covering the trachea. You can't swallow. You can barely talk. You're garbled. You're usually leaning over tripod like an old person with COPD. You're trying to find a little place where the airway's open the way you're sitting to be able to breathe. If we don't take care of it, you're going to end up with that obstruction completely. And this is the patient, when you know that this is what's going on, go get an intubation tray and a tracheostomy tray and put it at the bedside. These children might need an emergency trach at the bedside, because who knows, can you get the ET tube down? The epiglottis is covering the trachea. Can you push it through? So with epiglottitis, number one, you're going to try to figure out a way for breathing. And what we'll usually do is these children, the real bad ones, we'll have them sitting up. Of course, you try oxygen, but there's no air going in, right? Get an IV, get yourself some steroids, decrease inflammation. And then there's this aerosol called racemic epi. It's like getting a shot of epinephrine, but it's in an aerosol, and it goes directly back to the epiglottis and decreases the swelling, and hopefully will allow that child to breathe. Once that's done, you're going to put on usually a mask with moisture, and that helps it relax to then breathe a lot easier. I've only seen one case in my life this bad, but it is getting that racemic epi, getting the IV with steroids, and then keeping that kid calm. If that kid wants to sit not on the stretcher, on the mother somewhere else, and the monitor's stretched to there, they're comfortable. Oh, leave them there, because these kids, they're scared. They're air hungry. Can you imagine? Restless, like they're gasping. They're like really, really scared. Okay, that RSV I talked about, that cold for you and me, but as an infant, it's really, really bad. Children, the infants, are obligatory nose breathers. Now, put mucus in there. How are they going to breathe? They have to drink a bottle. How are they going to breathe? That's why it's a big, big deal. Now, put on top of that a child with, let's say, a cardiac condition, or was premature and has lungs that, they've been damaged a little bit through being premature and using supplemental oxygen for, could be 6 months, some of these children, these little newborns. So these children, you do not want them to get any of this common cold, or RSV, as we call it with infants. So what we do is give what we call monthly, not yearly, not once or twice, every month for the first year of life, starting now. If you're from up north, it's going to be from like late fall, winter to early spring. Now, I live in Miami, we do it a little differently, but it's about the first year monthly. It's about 6 to 8 months of the year they'll have them on there. And it will prevent them from getting it. Now, tonsillectomies, common, right? Kids are always their tonsils, sore throat, and when it's now the 4th time this year, they're having, sore throat, strep throat, they need to do something to stop these children from getting it. So we'll do usually a tonsillectomy, and we usually will take the adenoids out at the same time because it obstructs their airway. So they just do it all at once, usually an outpatient, and they do okay. But we have to send them home, and we have to send them home with the parents. And these children need to get proper care. So we need to teach them. So how do we teach them? Well, when they get home, they should avoid any spicy, seasoned, irritating foods. Because if you think about it, all they do is take and cut off the tonsils and adenoids, and there are cauterized scabs left in the back of their throat. So if you irritate it, those scabs can fall off, and I'm telling you, they can hemorrhage. They can hemorrhage, go into shock with the amount of blood that comes out. I've seen it 6 days post-op. Girl had just seen the doctor, ENT, cleared, came in, vomited once in the car, clots of blood, got to me, and she had a basin full of blood and clots. I picked her up, ran her into the trauma room, and immediately started an IV and fluid resuscitated her because she was going out. Hemovolemic shock. Can you imagine? So again, tonsils can be something that we have to worry about. So no seasoned food. Do not gargle, glug, 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 because guess what? That's going to cause those scabs to go away. Toothbrush, okay, just a little bit. You don't have to go nuts, especially in the back. Try to not cough, clear the throat. Don't put anything in the mouth, including tongue depressors. We don't do any of that. Tylenol and Motrin is all they need for pain. They don't need really much more than that. Older kids will let you put ice on their neck, and that helps. It helps with pain, and it also is vasoconstricting, so decreasing any dripping of any blood. And again, calm. Don't let them up running around going crazy, chasing their brothers and sisters around the house, because again, that can cause them to breathe heavy, can cause the bleeding to happen. Now, one of the things that happens And I had mine done it, believe it or not, at age 21. My tonsils and adenoids were taken out. And my ears kept popping and they hurt so bad. Well, they didn't tell me, but just chewing gum, older children, it can help relieve that. Now, one of the side effects, and you need to be teaching the parents when to tell the physician something's going on, is that if that mouth is smelling really, really bad, or they're starting with fevers, there's an infection. And yeah, your tonsils where that were removed can get an infection. Remember, your mouth is full of staph. It can be infected. Another thing, earaches that are bad or any cough. We don't want them to cough. They need to get to medical care. They say about 1 to 2 weeks out, they can get up and run around and be normal. But what happened after 1 week with that girl with me? So I would tell them to be pretty calm. Now, pneumonias, all sorts of pneumonias. We know we have aspiration pneumonia. How about that wonderful baby powder in the air that smells so great, right? Well, it might smell good, but we know that that powder in the air they can inhale it and it can cause problems, right? So there's always we can get pneumonias, or it could just be viral pneumonias and bacterial pneumonias. So we do know there is a pneumococcal vaccine that they get very young now to try to prevent it, because pneumococcal the pneumonia of that is very dangerous for children. So we are giving that earlier now, and that has stopped a lot from children getting pneumonia. Now, we mentioned pertussis, but they are getting their immunizations at 2, 4, and 6 months. We do. We give it to them, but many children, parents do not immunize their children. Their parents don't immunize their children. It could be for many different reasons, they religious or whatever. But the problem is those children can infect even those children who've had immunizations. Like you can still get chickenpox with a chickenpox vaccine. I mean, your chances are less, but it's still there. We had some cases in this county and the county above us a couple of years back, and we had to be very alerted to them. Highly, highly, highly contagious. These are children. They walk in, it's the N95 mask, get them into that reverse flow room, protect me, protect other children, okay? So pertussis, it's also called a whooping cough. Now, another thing kids love to do is put things in their mouth. And then something happens and they swallow it and it gets stuck. Now, that's a quarter in this kid's throat. They're never a dime, never a penny, never anything smaller. I have only seen quarters stuck there. And these kids come in, as long as their airway's open and they're breathing, keep them calm. We do the x-ray, we see where it's at. And do you know how we get that out? Now, years ago, we sent them to the OR and do a bronchoscopy and get it out. But it's an OR, it's anesthesia, right? Today, we have the surgeon come down to the ER. The child will sit, and they're usually that 1 to 3 years old, 4 years old at the max, sit on their lap, and they put a Foley catheter down the back of their throat. Then they blow up the balloon, and they lean forward, and they vomit and pull out that balloon. And then I tease the kid, if I get the quarter first, it's mine. So now they're not worried about what's happening. They're worried I got to get that quarter before my nurse does, so it's not scary. And now they're on the floor and they get the quarter before me, and everybody laughs, but the kid is fine. Didn't think about it. Then we'll monitor them for a little while and then we'll send them home. You know, that is easier than going to the OR. I've seen things as simple as a French fly get caught in the throat, and it got caught so deeply and toughly, they couldn't breathe. They ended up on like a heart-lung machine called ECMO, a machine to help you breathe. And the kid 3 days later didn't make it. from a French fry. So again, making sure that we are giving age appropriate and size appropriate of food to these children, because they do choke and everything goes in the backs of earrings, things up the nose. I've seen peas up the nose, beans up the nose, crayons, things in the ears. I see them everything. Anything I've seen probably. I already did otitis. It's just going backwards. Sorry. So aspiration pneumonia. Years ago when my kids were little, we didn't know anything, and I just love Johnson and Johnson baby powder, right? Smells good. Well, then we learned in the air it's not good for them anymore. So number one, we would tell parents not to use powder. Number two thing that can happen for aspiration pneumonias is the feeding. And how do we prevent this aspiration? Well, you've got kids going to have reflux, going to have GERD, and it's just, part of life. Some kids do. The things that we can do to help prevent it would be not overfeeding, burping well, during and after they're fed, and having them sit up when they're done so that they can spit up a little bit and they don't have to aspirate it. Now, one of the respiratory illnesses that's covered is cystic fibrosis. Now, cystic fibrosis is mucus in the lungs and in the small intestines, and it clogs everything up. One of the things with cystic fibrosis is at birth, if we didn't know this kid had cystic fibrosis, they will not have any stool for 2-3 days. And newborn infants usually have that meconium start almost immediately after birth. There is no stool, and they will check. Now, how do we check for cystic fibrosis? Well, it's something called a sweat test. Cystic fibrosis children lose sodium, salt, in their skin. If you were to lick a child's skin that has cystic fibrosis, it would be very salty. So these children need salt in their diet because they're losing it like crazy, okay? Now, the upper airway part is all this mucus in their lungs. And one of the things has to be done on a daily basis is good respiratory care, good pulmonary toileting, which means aerosols. They put those vests on that move and they rumble. Maybe you'll be able to see one when you go to daycare, to your clinicals, but it's a vest that just rooms after they have the aerosol on. Then you're going to do postural drainage, and hopefully they can spit up, or you can help them spit it up. Another thing is there's mucus in their small intestines, and the pancreas isn't working the way it should to help break down it. So these children are going to have different looking stools. They're going to be the worst smelling stools you've ever had. And then they're going to be greasy because they're not digesting any fat. Fat's one of the highest calorie contents, right? Protein and carbohydrates are, 4 calories per gram. Fat is 9. So you're not getting calories. These children are not going to be growing the way they should. Now, as I said, you're going to do that sweat test. It's going to be looking for that sodium chloride in the sweat. And how are you going to treat it? Well, I've already told you what we do for the lungs. All good pulmonary toileting. I mean, you've got to be aggressive. And it's morning, noon, and night. It's just not once a day. It's sometimes every 4 hours, depending on your child. And remember that mucus in there is like a big petri dish. It grows bacteria. So they're in chronic respiratory infections. So they're on antibiotics all the time. So we can loosen up those secretions, take care of those infections, and then we do that the chest physiotherapy to get rid of the mucus so they can breathe. And then the other one, as I said, is pancreatic insufficiency. And we give these little capsules. And it's part of your NCLEX questions. You probably will get the question on what do you do? Now, the thing about cystic fibrosis, you don't grow out of it. It is a lifetime unless you do transplants, okay? But let's say you're not doing transplant. You're going to be on pancreatase medicine for life. There's capsules and there's powder. There are also enteric coated beads. Now, the beads in these capsules, you can't chew and crunch. Just like any other enteric coated medicine, you're told to swallow it whole. Okay, that lining there is for protection to get it to where it needs to go. Okay, enteric coated aspirin protects the stomach so it gets into the small intestine. So we never chew or crush them. You can open the capsule and put it on the food, and it should be immediately before you eat, or it should be some of the kids, you have to put it in the food as they're eating. They're getting this medicine, and it's for snacks and it's for your dinner time. Now, if we have to use powder, it's just like using things like your Symbicort and your Brio, where you have to wash your mouth out because it can hurt the enamel on your teeth. So you always rinse your mouth after. And the one thing I think we forget in pediatrics a lot is to change the dosages as they get bigger. Now, cystic fibrosis, women can get pregnant, but because it's a pancreas issue, they're going to have a higher risk for getting diabetes and, of course, gestational. You can get pregnant, but it's high risk. Now, men cannot produce sperm. It can't get to where it needs to go. So what they say with men is they have to do a bilateral lung transplant, and 1 year later, they're able to produce the sperm. Their vas deferens doesn't work right until they do this bilateral lung transplant, and then they're able to have children. I mean, this would be the man who, gets married, wants to have kids. They'll go to the risk of having that lung transplant, the bilateral, in order to have the ability to have children. But the women, again, is also very high risk. But it's the men that get that transplant that now that they can do their part and use their sperm. Now, acute respiratory distress syndrome could be due to many different reasons. In children, the biggest reason for anything is always infection, sepsis. That's one thing that you could say. It's one thing that we need to watch out and very closely with. It could be trauma, chest trauma, car accident, fell, off a balcony, could be ran over by a car, I've seen, anything. Of course, the older children, drug overdoses, and then, of course, near drowning. And these children have had a serious injury to their lungs. Now, if you're looking at all of that stuff there, that is what we call ECMO. It's how we pull blood off, oxygenate it, and put it back into the child. We do it for young newborns for many different reasons, but they can't oxygenate on their own, even intubated, even with high-level respirators. They just can't. So we have these machines working for them. Even so, many of these children die. Now, CPR is something that we do. And it used to be your child in CPR, we used to throw the parents out of the room. We didn't want them to see it. Well, today we've realized that if the child dies, wouldn't you want mom in there to know that we did everything we could and that they were holding that child's hand? At least they were there. So many of them will say no, or, well, maybe something's happening. They can't, but they can be at the door. Make sure somebody's with them. Make sure that somebody's there letting them know what's going on and they're updated. CPR, if you can imagine your child getting CPR, how would you feel? And what would you want? One of the most common respiratory conditions in children is asthma, right? Asthma is something that hopefully they'll grow out of, but not all children do. And it's just something that makes the lungs swell. It's like we call that hyper responsiveness, and they swell. And this is expiratory. You can get air in easy, the upper airway's fine. It's down below, it's swollen, and the air gets trapped, and you can't get it out. Okay? It's due to allergies, antigens, all sorts of things. So, how are we going to treat asthma? Our goal in asthma is to prevent them from having asthma attacks, right? Now, I'll give you a little insight. A couple years back, my husband went into an asthma attack. He was in the ICU for 12 days with status asthmaticus almost the whole time. The only reason why he wasn't intubated is because I was there calming him down, and he just had that BiPAP machine on instead of being intubated. Because once you're intubated, it's a long time to get them off. So I wasn't going to let that. I didn't have to. So that's our goal with children too. We don't want them to get there. So we will do pulmonary function tests when their lungs are the best they can be. And we'll do allergy testing, finding out what to avoid. Is it cats? Is it dog? Is it grass? Is it pollen? What is it? And our goal is also to keep these kids active. But if we find out they are allergic to grass, they're not going to be running around playing football, rolling around in it. Okay. So maybe they'd be swimming or bowling or tennis or something else. So our goal is to prevent these attacks. One of the things we do is we have our rescue, our albuterol, right? Proventil, whatever, Ventolin, whatever your name of it's for. It's a rescue. It dilates the lungs and lets you breathe quickly. But on a daily basis, we take morning and night medicine. In children, we give something called Pulmicort, levoalbuterol, and it's a slight steroid to it. It's like in the adults, it would be Atrovent, a little bit of steroid in it, and it helps decrease the lungs' hyperresponsiveness. Another thing that they do is they give them Singulair. Singulair is a Claritin for asthma, and when you do that at night, and then in case it starts to flare, we'll add things on like steroids, prednisolone, Orapred, whatever name that you know. Okay, hearts. Okay, this is confusing. Adults, children, doesn't matter. In children, when we talk about heart, we talk about congenital heart defects. We know you're either born with it or maybe you acquire it. Usually when you acquire it, it's more of a cardiomyopathy due to a viral infection, an immune response. Could be lupus, right? Lupus can affect your heart. So those are things. Now, this is the picture of blood flow. If you don't remember it, it's something you need to know the names of the chambers and valves in the heart. Okay? So I'm going to describe it, and then I'm going to tell you a little thing on this picture. So blood comes back after going all the way around the body, comes back through the vena cava, and it goes into the right atrium. So pressure going into the right side of the heart is very slow, very low, because it's the end of where it gets in there. It goes through the tricuspid valve into the right ventricle, and then it goes up into the lungs through the pulmonary artery. After it gets oxygenated and CO2 is let go, it comes back through pulmonary veins into the left atrium. Now our flow is getting higher, okay? It's 4 pulmonary veins, and they don't teach you that. I learned that working in cardiac. It's actually 4. Goes into that left atrium, so it's big flow. Goes through the mitral valve, into the left ventricle, which is that engine for the heart, right? Pumps the blood around, that big muscle. Goes up the aorta, and it goes down the aorta, and then it feeds the body. And it repeats. Now, I ask you a question. When it comes out of the aorta, and it's on that arch coming down, if it's kinked, it can't go down. is called a coarctation of the aorta. Where do you think that blood's going to go if it can't go down? Areas of least resistance, right? It's going to go back into the left side and go back into the lungs, right? This kinked, it can't go that way. Think of it as a hose. If you have a hose kinked, water can't go out there. It's going to go back to the faucet and squirt out the faucet or through any hole in the hose, right? Well, it's the same thing with blood. Now, coarctation is one of those diagnoses that you will be tested on. Coarctation, we have hardly any blood flow going down to the lower body, okay? So what would you see at birth? And I actually diagnosed one in my career. I was so excited. You don't have much blood flow going down. So when you're testing pulses in the lower extremities, you are not going to feel a pulse, dorsalis pedis, posterior tibial, doesn't matter which one. It's going to be extremely weak or non-existent. So then what do you do to say, I think this coarctation? Well, as I said, blood can't go down, it wants to come back. And you see those three little knobs on the top of that arch? Well, that goes to the upper body. So you're going to see all the blood up top. So you're going to have blood pressures on the upper extremities are going to be high because that's where all the blood is. And if you take blood pressures on the lower extremities, it's going to be lower. And that's the key thing that you see, the differences in blood pressures. So again, coarctation. Uppers are going to be high and lowers are going to be lower. How do we treat it? Well, they're going to have to do surgery, right? They have to open it up. And it's usually just a thoracotomy. And they go in and they quick switch it. But that left ventricle is under pressure because blood's coming in both ways. And it can't go there and it can't go there. So usually these children come in severe congestive failure because it's the only place where it can go, into the lungs. Now, many times children go home and we don't catch stuff. I mean, it's not uncommon. You're in and out of the hospital in a day or two now, right? It used to be a week. Now, mothers are in, have their baby, they look good, they're sent home. And all of a sudden, it's 2 months later, you're going in for your immunizations, the kid's not gaining weight, not eating well, and you're going to see a kid breathing fast, the heart's beating fast, and then you're going to see not getting nutrition, they're going to be delayed, right? They're not even trying to hold their head up at this point. So when we see those sort of things, and they're burning calories like crazy because of this heart condition, trying to get oxygen where it wants, you're going to see a child not eating, not gaining weight, tachypnic, tachycardic, and going to be delayed. Your growth and development is absolutely going to be delayed. So one of the things that you would give as a nursing diagnosis is inadequate oxygen perfusion leading to activity intolerance resulting in diminished energy to feed. Children with severe congenital heart defects will be tiny. They're burning their calories in their heart. These children are usually on the 10 percentile, 25 percentile, maybe. These kids will be tiny. It's the way that their heart is. Plus, they tire out easy eating. Now, when we're inspecting these children, we're going to ask them, especially if they're coming in with these symptoms. You're in the cardiac ICU now working, you get this child in. What are they eating? How often do they eating? What is the color of the child? I mean, that one on the right, you can see the purple, the cyanosis, oil, oral. O2 saturations could be, I've seen them as low as 65. And that's due to, some of these cyanotic heart defects. Look at the heart. Is there a murmur? Sometimes you put your hand on it, you can feel the buzzing. Those murmurs are incredible. And as they get older, you'll see clubbing, not early. You're always going to listen to the chest, the abdomen, feeling for those peripheral pulses. Is it that coarctation of the aorta? Some of them go home with coarctation that somebody didn't catch because it wasn't complete. It was just a narrowing, right? And now we're seeing all the blood going into the heart, and now they're in congestive failure. So looking at the rate, the rhythm, heart sounds, etc., will help. When they're admitted, we put them immediately on an EKG and we do a 12 lead. We want to see if there's any problems with their rhythm. Then we're doing echo. And that is a picture of them doing an echo, just on their chest. And the echo's looking for any abnormalities of blood flow. If you find that there is some sort of abnormality, prepare that family. They're going to go for cardiac catheterization next. And that cardiac catheterization is going to show where the defect is. And then the cardiac surgeon can get together with the team and decide what is the best plan for surgery. Now, you also see sometimes it's interventional. This electrophysiology studies. There are times with hearts that somewhere in that right atrium is making a beat. I mean, it should start on the SA node, the sinoatrial node, right? That's where a heart beat. That's where it should come from. But sometimes somewhere in the right atrium says, oh, I want to start the beat. Well, any other place could have a heartbeat of 240 or 300. So all of a sudden you're going to have tachycardia really fast and then normal, and these spurts. And sometimes it causes dizziness, causes them, to pass out, et cetera, et cetera. Well, an electrophysiology study or an EP study, you'll have these special cardiac cath physicians who go in, find out where in that right atrium is trying to beat, and it zaps it. And it says, oh, no more, zap. You're dead. You're not doing that anymore. And it creates that heart to beat regularly, consistency, without those speed up times. So cardiac cath, now we need to know what to take care of them, right? We know that pre-procedure, they're going to be held NPO, but they're not going to be held from 12 o'clock on, especially if it's a newborn. They can have breast milk up to 2 hours prior to procedure, usually, because they consider that actually a clear liquid. So you send them to cardiac cath. You send them in their bed, you send them in their warmer, whatever they're in, you send them, and they come back. Now, remember, they put catheters in the right femoral artery and the right femoral vein. And that they shoot dye in there and they look at the heart. And then when they're done, they pull these catheters out, and these are really big, okay? So they have to hold pressure on where those catheters were until they stop bleeding. Then they put a big pressure dressing on there, and older children, they might put a sandbag on, usually not newborns because it's too much. Even a 5-pound is a lot of weight. Sometimes it's bigger than the kids, okay? So they wouldn't put that much weight. So they come back to the OR. They've taken off that table and cardiac cath, put back on their beds, back on their warmers. They're rolling down the halls, bouncing around. They get to the room. Number one, please look at that dressing. The biggest risk is hemorrhage. Can you imagine these big holes that are in the artery and a femoral vein squirting blood? It won't take long for them to exsanguinate, will it? So number one, check the dressing. Make sure they're not bleeding, okay? Number one. You're going to check pulses, and yes, that right leg is going to have decreased because we've just, threaded it with these big catheters, and there is going to be some swelling inside. So we know that. So document it and let the next nurse know, and take vital signs. They need to still eat or drink, so make sure that we either have IVs or they get some fluids. And one of the things we check is glucose levels. Sometimes they don't give any glucose in the procedure, their blood sugars are low. Sometimes they give glucose, and then blood glucose levels are high. So we want to know where we're starting at, okay? Another thing, you can't get these children out of bed for 24 hours. Why? We don't want that clot on those vessels to dislodge, okay? That leg must keep straight. And you can slowly raise the head of their bed, but you don't want to do anything quick, anything to put undue pressure so that it could start bleeding, okay? Especially for your older children who are in beds that can have their heads bent elevated, okay? So in bed, keep that right leg straight, check that dressing, make sure you check your vital signs, pulses, and glucose. Now, congenital heart disease, before I started working in the cardiac intensive care unit and not just newborn ICU, I didn't realize how many congenital heart defects were there, more than I had ever imagined. It is the major cause of death in the first year of life after prematurity. Now, one of the most common of all the defects is a hole between the ventricles called a ventricular septal defect. That wall between the right and left side is called a septum. That's why it's a ventricular septal defect. Now, Down's children have a higher risk of having congenital heart defects. Could be VSD, AV canal, truncus. And you don't have to know those other two, but these are just more complicated ones. I'm not going to show you all of the congenital heart defects because it's just too much at this point. I want you to know a VSD, and we'll continue here the stuff that you need to really know. So remember, in any wave fluid, there is always where the blood is going to flow. And I found a picture here, I think sort of describes it. So as I said, remember the right, where is shunting? Now, shunting means going from high pressure to low pressure, right? Going to where there's spaces there. So if you have a hole in the septum between the right atrium and left atrium, remember that left side has 4 veins pushing it in there, right? So the flow is high. In the right side, it just gets back there. So blood is going to flow to the right side. So what happens, it goes back into the right ventricle and back up into the lungs. And what we say is it just reflows into the lungs, whether it is an atrial septal defect or a ventricular septal defect, you're going to have an increased pulmonary blood flow because that's the level of least resistance. Goes from the left side to the right side. Now, one of the terms is acyanotic and cyanotic. Acyanotic means even with an ASD, you're still going to have good saturations. VSD, still good saturations. They are acyanotic, A without, not with cyanosis. And then there's cyanotic, and we're going to go into some of those here now. So as I said, increased pulmonary blood flow, ASD, VSD, atrial septal and ventricular septal defect. Now, another condition that we have that children are born with is from fetal circulation is called a patent ductus arteriosus. This connects the aorta to the pulmonary system. So it's the pulmonary artery and the aorta. There's a tube that connects them. So we know no matter what's going on in the heart, that lung is feeding the aorta. We're getting blood to the body. That's a patent ductus arteriosus. Now, at birth, mom produces something that we call prostaglandins. It's a hormone, and it keeps it open during pregnancy. Once the baby is on its own, there's no mommy's prostaglandins and it closes. And usually that's okay. But sometimes we need that open in order for oxygen to get to that child, because not every kid gets oxygen. and we have to reroute it sometimes. Now, I've already talked about that coarctation of the aorta. That's that kink in the hose, right? That means no pulses or decreased on the lower extremities. Next thing you do is that 4 extremity blood pressure. And because there's hardly anything down below, low blood pressures. And because all the blood's going up, we're going to have high blood pressures on the uppers. Stenosis is a narrowing. Atresia is A without nothing. So tricuspid atresia, where's the tricuspid valve? It's between the right atrium and the right ventricle, right? If there's no opening, that blood is not getting to the lungs, okay? Atresia without. That's when you want your PDA open, because that's the only oxygenation for that child. And we'll go into some of it more. Tetralogy up below, the most common of all cyanotic heart disease. Ever hear of a TET spell, blue baby? This is where the pulmonary artery just kinks off and doesn't let blood go up. I was taking care of my little Nathan one night at 4 o'clock in the morning. I was just changing his diaper and just combing his hair, making him pretty. And all of a sudden he had a TET spell on me. He went from an O2 saturation of 100, and within a minute, hit O2 saturations of 10. No blood was flowing into his lungs. So that's your knee chest, where you push your knees to the chest. And if you think about, take an infant, press them, like, why do we knee chest it? Well, the abdominal cavity has a pressure, and the chest cavity has a pressure. And when you do the knee chest, whether they're older children who squat and take care of it, or babies will do it for them, it changes pressure, and it sometimes will relieve that flap that's covering the pulmonary artery and let blood flow. Now, the other confusing one is the mixed blood flow, cyanotic, transposition of the great arteries. This is where you have the aorta, where the pulmonary artery should be, and the pulmonary artery is where the aorta should be. So you have 2 blood flows, and nothing is getting oxygenated, and nothing is going to the body. Again, this is where that PDA, that patent ductus arteriosus, that connects the lungs, pulmonary artery, to the aorta, will let blood flow go on. This is something where we could make a little balloon, that atrium. You know, when you're born, you have a little hole in between your 2 atriums, between the right and the left side. And it's a patent foraminal valley, and we'll open it. And what that does, it lets blood flow that way a little bit. And then we will take, when we have this child in a chance, we have them with that PDA open, and we're keeping it open. And I'm going to tell you how we do that in a little bit. And then we do surgery, and it's called an arterial switch. And the surgeon literally takes the top off the heart and turns it around and puts it back on. So it's a massive surgery. Children do well with it, though. And then the last one I'll just mention is hypoplastic left heart syndrome. The left ventricle is non-existent. It doesn't pump. You're not getting blood anywhere. It's just hypoplastic. There's a very little narrow opening. The blood goes, but nothing's pumping it around. The most severe and the most devastating of all congenital heart defects. So here we are again. Let's talk about it again. PDA, present at birth, right? When would you know that it's there and it's open? Well, you can hear, it's like a washer machine type of murmur when you listen. Another thing, children who come in with cardiac conditions, the surgeon will usually put in an arterial line to monitor them, and they're going to need that for surgery too. So usually a normal blood pressure on a neonate, newborn infant, is 60/40. It's like 120/80 for us. Same thing. Well, what happens if this is opening, that connection between the aorta and the pulmonary artery is open, that PDA, your blood pressure it's a wide pulse pressure. 60/18 is not uncommon. So we know that that is open. Now, sometimes, as I was telling you, we need to keep it open, right? Like that transposition of the great artery, that tricuspid atresia. There's no blood flowing to the lungs. We're not getting oxygenated. So I said mothers produce a hormone called prostaglandins to keep it open when they have the baby inside, right? Once they give birth, prostaglandins is gone. So there is a synthetic prostaglandins, and it's a very slow, continuous infusion. It's not like every 2 hours. No, slow, continuous infusion, and it maintains cardiac output and it keeps those oxygen saturation levels where you need it, right? Because the lungs is going right to the aorta, right to the body. Now, there are moments, and a lot of times I see this with a lot of premature infants. For some reason, that PDA doesn't close normally, and they have to close it. Now, they don't need to do surgery. What they can do is give something called indomethacin. And what's crazy, this is actually an IV NSAID. When I first heard this, when I went into pediatric nursing, I was like, Indocin or indomethacin, you take that for backaches, is what I knew it for. I'm like, where did this indomethacin come from? Well, they give 3 doses and they monitor their kidney function really closely while they give it. And you'll start to see them close. Now, how would you know a PDA closed without doing an echo or looking at it? Well, that pulse pressure is going to return to normal. So 60/18 now is becoming 60/40. And that murmur that you heard, it disappeared. So you don't even need an echo. You can tell just by those 2 things alone. And I used to like to watch the numbers change. So increasing pulmonary blood flow, I've already said it, ASD, VSD, PDA. This is just a little bit more for you to look at. It explains it a little more. Flow from from the most flow to the least. More obstructive, I talked about coarctation. And then, as I said, the most common of all is tetralogy of Fallot. Obstructive, there's none. And there's your tricuspid atresia, means there is no opening. And then we have all these mixed ones too. So those are something for you to look at. I've gone over them. I don't want to go too crazy on them because right now I know you're going, oh my goodness, how am I going to remember all this stuff? That's why I gave you that handout. Congestive heart failure. Is there anything different between the adults and the children? No, it is still a heart that's not beating right and blood is going back into the lungs. It could be obstructive or just a weak heart. But anyway, you'll see it go backwards. Mostly in children, it is structure, okay? Adults, usually it's a weak heart. In congestive heart failure, what do you see? Well, if you have a child who you're feeding and they're starting to get tired easily, they start to get tachypnic, tachycardic. Sometimes you even see them sweating. Listen to their lungs. Most likely they're in congestive failure. Telling the physician what's going on, do an x-ray, and that's all white out. That means that, lungs are full of fluid here. So what do we need to do to take care of congestive heart failure? Well, we want the heart to beat better and we want that fluid gone. So we give furosemide, Lasix, right? Fluid, get rid of it, get rid of it, get rid of it. And simple digoxin. Digoxin has been around for 50 years that I know of. Also, it's safe. And we do give it in children doses, mics per kilo. It will improve the cardiac function, remove the fluids, decrease the work, and now the baby's oxygenated. How do we know that stuff is working? Daily weights, intake, output, right? If we are getting rid of fluids, we're doing weights, they're decreasing. And then how are they breathing? How's their heart beating? If it's going down to more of a normal, we know all of that's working. So with digoxin, a child can't tell you things like they see yellow spots and whatnot that you would see in dig toxicity in adults, but you're going to give it almost the same way as an adult. You're going to count an apical pulse for 1 minute. You're going to check the potassium level. It has to be 3.5 or higher because a low potassium can cause dig toxicity. If you have a digoxin level, you're going to check it. And the one thing with infants that they can show you besides a lower heart rate would be vomiting. If I have an infant who's vomiting on digoxin, I'm going to tell the doctor I'd rather be safe, get a dig level, and make sure that their dig level is not too high. Okay? Vomiting might be the only thing you see. You might have a lower heart rate, but sometimes not even that. So we're just going to be monitoring these children. These kids congestive failure. Sometimes they can't eat with a bottle. Sometimes they're tube fed to get their nutrition in them until they get strong enough to be able to suck, swallow, and breathe normally. And again, they're burning calories. So we have to remember this in nutrition. Hypoxemia. Now, many cardiac children, normal O2 sats at birth are 65 to 85. That hypoplastic left heart syndrome I said about, that one is going to be that low. And that's actually where you want it to be for many different reasons. Now, what happens with that child whose O2 saturations are less than normal? Well, the body is pretty neat. And it says, I need more oxygen. So how is oxygen carried around to the body? By red blood cells. So what does the body do? It makes more red blood cells. There's no more oxygen, but what happens is your hemoglobin and hematocrit, which should be maybe 14 and 52, go to 18 and 60, right? You can get that high of levels because the body is trying to help itself, but there is no oxygen. So polycythemia is one of those things that we look at. That blood is like a thick maroon look, and you'll see it if you ever work in the cardiac unit. And this is a picture of what clubbing would be on an older child. Probably that hypoplastic left heart child would look like that. So now you've got a child in, and mother's been told your kid has a cardiac condition, whatever it is. Some of them know it today because of those special 3D cardiac echo things that they do. But sometimes they're not, and they haven't been done. They didn't expect it. Well, you need to let that parent adjust. This perfect child now, there's a problem. They're not as perfect. And many times I'll tell this parent, it wasn't the Tylenol or that little glass of wine you had in the first trimester before you knew you were pregnant. Because their mothers feel guilty about anything. Was it this? Was it that? I went out dancing or this, it's none of that. There is so much that happens in fetal development that it's amazing that hearts are as normal as they really are. When you're working with these children, always, as you do stuff, you're always talking, you're always telling parents what you're doing, what you're listening for, what you're looking for. If they're going for cardiac cath, surgery, anything, as much preparation as you can is so important. Seeing your child with tubes hanging out of everywhere and a breathing tube and NG tubes and Foley catheters and tubes in and out chest and the chest opened, and this can be really difficult for parents. So really prepare them. And then, of course, after surgery, as you're doing things, removing things, telling what you do, how to care for those things, getting them ready for discharge and home care. Again, there's cardiac cath. I've gone over it. Just another re-up on you about what to do. Bacterial endocarditis, again, this is an infection. These are children which will be getting prophylaxis before anything, dental or any procedure. Now, rheumatic fever is one of the conditions caused by a strep throat that wasn't completely treated. So strep throat again, you think it's all strep throat, antibiotics, I'll be all better, right? Well, this is one also that can become dangerous. If they don't treat it completely, or if they don't follow up with the doctor and it continues, it can cause permanent heart valve damage. It also affects joints, skins, rashes. It can go to the brain. It also can cause something called chorea, which is these different movements, that are just uncoordinated. Now, how do you treat rheumatic heart disease? Well, hopefully it didn't get that valve, because once it hits, and it's usually the mitral valve, and once it's hit, there's no coming back. But everything else will turn around. All of the joints, the skin, the chorea, the movements, they will all go back to normal. And the treatment is long-term antibiotics. It could be 4 weeks, could be 2 months. It all depends, okay? So you have a kid who's sore throat, has rashes, the joints are swollen, funny movement. Has your child been sick lately? Oh, they had a strep throat and they treated it. Well, that's your answer right there. Anti-streptoliftin factor, ASO, is going to be positive. They can have high fat. They also can have dysrhythmia, slow, fast, or, with dysrhythmias. Especially your younger premature children, the way that we treat them with oxygen, etc., during that beginning phase, we can damage lungs and cause pulmonary artery hypertension. And one of the things that I found back in the cardiac ICU is Viagra actually is a treatment for pulmonary artery hypertension, which I thought that was really interesting. We know that if you have pulmonary artery hypertension, that means you're not oxygenated the way you should. You're going to see dyspnea with exercise, that chest pain and dizzy, because you're not getting oxygen. As I said, cardiomyopathy, usually due to a viral, but again, this could be lupus that's going on. The heart gets big and floppy, and it gets to the point where it can't work, and then we look for transplantation. The biggest concern and reason of death is rejection. And remember, they will be on anti-rejection drugs for life. Many cardiac children will get chest tubes, right? Because their chest has been open, their lungs have been there, and they put in maybe 1, maybe 2, maybe 4. And I've worked in the adult world, and I worked night shift, and they love to come in at 6 in the morning and remove all the chest tubes. And the adults tell me that it burns intensely for 30 seconds and then it's gone. So how are we going to take out chest tubes on children knowing that little information that I knew? Well, number one, you're going to medicate them before they pull those tubes. And you're going to tell that child it's going to hurt for a second. But I've given you medicine, but that hurt, that ouchie is going to go away quick. And I'm going to hold your hand. Take their vital signs before you give them pain medicine. That's part of your protocol. And after the procedure, making sure they're doing okay. And always get on their level. Let them understand on their level. And the honesty is the biggest, most important part. Having them sitting up a little bit helps it come out easier. Children get hypertension, and we're not, years ago we didn't treat or even take blood pressures on younger children. And then what does hypertension cause in adults? Kidney damage, right? It does do that for children too. So we're doing now younger. We're doing blood pressures on all children. Now, Kawasaki disease. Kawasaki. Kawasaki disease is a systemic vascularitis of unknown cause. What does that mean? Well, some of the vessels get inflamed, and we're mostly concerned about coronary arteries. They get inflamed and they flick off little microembolus. What do you see? These children usually start out with fevers. Then they don't feel good. And this is now a week later, several doctor's visits. Now all of a sudden their eyes turn glow in the dark red. I'm talking red, red, red. Their lips get chapped. They got strawberry tongue. If you look at their hands, their palms of their hands, soles of their feet, it gets like the skin starts peeling off and blistery on it. And then you'll see this little fine little rash all over. So usually these are your younger kids. Our biggest concern is that vascularitis, and that's that little microclots, right? So how do we treat it? Well, we give intravenous immunoglobulins. It's not a bacteria. It's not a bacteria. We just boost the immune system by intravenous gamma globulins or immunoglobulins. And we give high dose aspirin. Why aspirin? It thins the blood. It helps prevent clotting in the coronary arteries, which could cause a myocardial infarction. And those are some great pictures of things that you see with Kawasaki. Once you cure this, and it's usually about a month of treatment, usually they don't get it again. And our biggest concern when they're diagnosed is to get an echocardiogram and look at those coronary arteries, making sure there's no sort of aneurysms going on there. That is the biggest concern. Shock. What's the biggest cause of shock in children? Infection, sepsis, usually. And we treat it just like adults. What is it? Low heart rate, high heart rate, low blood pressure, decreased capillary refill, decreased urinary output. And if they're old enough, they're not going to be as alert as they were. Shock. Blood is not going where it needs to go. Usually, as I said, infection is a big thing. All right, here we are, the big question. Surgical closure of the patent ductus arteriosus would do what? Where is it? Pulmonary artery to the aorta. It's there for fetal circulation. It's kept open by mommy's prostaglandin, or we keep it open with a slow, continuous infusion of synthetic prostaglandins. So if we close it, what happens? Well, it stops that oxygenated blood from going back, right? Because we're preventing it from reflowing in there. One of the questions is ASD, VSD, PDA has to do with increased pulmonary blood flow. So it stops it. It's a lot. As I said, cardiac respiratory is huge. It's a big thing. I did give you that matching sheet. It's something you should go through and you should look at, okay? It will help you understand those key areas that are important. So who wants to win the Kahoot today? It's a rough one. Nobody's hands are up today? Come on. Thank you, Kurt. Thank you, Thomas. Yukari. So I don't mind you trying, you try, that's all you need to do. It's the way we learn. How do you think I learned all this stuff? Well, I worked in the cardiac ICU for 10 years. There's 59 questions. I'm going to try to get through them as quick as I can. If it's 5:30 and you have to go, I understand. But as I said, this is the of all the classes the longest one. I mentioned it first day, but this is always the longest one, just to make sure that you're getting the information that you do need. All right, we're going to get going, try to get out of here, get you at a certain decent time. Respiratory cardiac. A majority of upper respiratory infections are caused by what? They're mostly what? Viruses. Remember, there can be bacteria, but mostly upper respiratory are viruses. That means Tylenol, Motrin, liquids, rest. You walk into a 6-year-old room and you find them not breathing and does not wake up. What do you do? If you work on a regular unit that not on monitors, this can happen. And now what they say is start chest compressions. And it's not breath first like it used to be. It's chest compressions. And you're yelling, hey, call 911, right? If you're or telling the other nurse, call a code, or you're hitting that code button over the head of the bed. They usually have the big blue button to hit. A multi. What are some signs and symptoms that smaller children may exhibit that have a respiratory infection? We know it starts with that they get the fever and then they stop eating and then they can do everything else. Yes, they can. Get the fever down and they'll start drinking and it'll look like they're not even sick. What do you look for when assessing respiratory function? A little bit of everything, isn't it? We're going to look at, how fast or how deep. Is it labored, retractions? Is it easy? Inspiratory, expiratory wheezing, all of those things. What would you look for after a child has a tonsillectomy? I mean, we know how to treat it. We talked about it. But what's something that you're going to say that this isn't right? Remember, there's these big scabs in there. The big thing is swallowing, and why? It's the back of the throat. They're bleeding. They're swallowing it, and that's why. You shouldn't have a fever. Some of them won't drink. It's not severe pain. It hurts, but it's the swallowing. That's the danger. That's danger. They're bleeding. Nursing care for a child status post tonsillectomy include I think our biggest goal with tonsillectomy is making sure they have the ability to take liquids. I mean, liquids is the big thing, keeping them hydrated, giving them the pain medicine. The older kids, the gum relieves that pressure in the ears, and an ice bag if the kid will allow it. Younger kids don't like it. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? Which one is it? Tracheal bronchitis is the same thing as bronchitis. It's a different name. It's more anatomical, okay? And that's why this question's here, to show you tracheal bronchitis, bronchitis is the same thing. What signs and symptoms would you see in a child with otitis media? So ear pain is huge. I mean, these kids are whimpering and crying. It's so bad. Sometimes you do see the drainage, not always. And again, when kids are sick, they stop eating. Rarely do they have fevers, believe it or not. Otitis does not mean a fever. Not always, no. The monthly immunization for RSV is which one? And it is Synagis. And you see it's a biologic, right? Pavizumab, that mab. So it's either name. I think today they have to use both on the NCLEX. All of the following are signs of early respiratory distress in children, except everything but bradycardia. When you're in respiratory distress, you're tachypnic and you're tachycardic, you're restless, and you can become diaphoretic, right? Bradycardia, that child's about to code an arrest on you. So you better have a code team called. Bradycardia, the child's given up. The body's had enough. A 4-year-old child's been taking meds for asthma, and the child is still wheezing. What information is important to ask? You need to know about that. Now you're talking a 4-year-old kid. Are they taking the medicine how? Are they squirting in the air and trying to breathe it in? They do the spacer, they're getting the medicine. So if they're on asthma, they're still wheezing. Are they getting the medicine or is it just spraying into the air? Okay, very important. Spacer's a little tube that you put your little aerosol, the meter dose on the end and squirt it, and you can breathe it in and out, and you could get all the medicine in. We use that on your younger children, even some adults who can't push and at the same time, they use spacers. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? Well, what are signs and symptoms of respiratory distress? Tachypnea, tachycardia, restlessness from hypoxia. The only one that makes sense here is they're retracting, they're restless. And remember, it's inspiratory is croup. It can't get it in because that epiglottis is swollen, okay? Inspiratory. Signs and symptoms of asthma include all except And this is a tricky question because when you know a child or adult have asthma, they can't get air out. And you'll see a prolonged expiratory phase. With my husband, I could hear air going in barely, and that was the pushing it out. You can breathe in and then it's trying to get it out. You have to force it out. So again, asthma's expiratory, croup inspiratory. Remember the differences. Signs and symptoms of congenital heart disease include all except remember congenital heart disease, the heart's not formed right, it's beating differently and weirdly and burning up calories because of that. So their weight gain is never appropriate. Very good. You listened well. Good. What should you not do to children diagnosed with croup and epiglottitis? Put tonsillectomy in there too. So you don't ever want to look in there because the oral pharyngeal airway could get, there's swelling in there already. You don't want to do anything to make more swelling. So you do not open their mouth and look inside of there. The epiglottis is what? What's an epiglottis? What does it do? It's that leaf-like cartilage that prevents choking and it covers the larynx so that food don't go into the lungs when you swallow. It goes down the esophagus. Very good. Treatment for infectious mononucleosis include well, what did I tell you about mononucleosis? Is it bacteria or is it viral? Right? That's number one. What type of infection is it? And then how do we treat it? It's viral, no antibiotics, no contact sports, really protect that abdomen, rest, and then just antipyretics and liquids. Make sure you check in with a physician for PE about after 3 weeks. So no contact sports and no PE for at least 3 weeks on those children so that spleen or that liver can stop from swelling. Multi. When doing an admission on an infant with a low-grade fever and a loose cough, what information is important? What do you need to know? They're being admitted to your unit. APGAR's not really needed. The only thing would be if there was a prolonged admission, at birth. But what is their fevers? Immunizations. Where am I going to put that kid? With another kid who has immunizations, or did they not get, or are they not caught up on their immunizations? You wouldn't put them together. And of course, when was the last Tylenol, so that you can medicate them again? What is cystic fibrosis? I like it where you go blind in one eye. Again, it's lungs and digestive system. It's not just the lungs. Remember, it has to do with the pancreas, and now you need enzymes to eat to get your nutrition to help break down the food. What is the greatest risk for an infant having a cardiac catheterization? Biggest risk. Remember cardiac catheterization, they suspect a congenital defect. They put two big catheters up the vein and the artery, femoral artery, and they inject eyes and look around. That hemorrhage is big. And if you ever seen it, it is quick and it comes out quick. How do you treat that? What would you do? You take your fingers, two fingers on that femoral artery, just above it, put pressure. So you still can see the holes, but your fingers are above. And then, of course, call the doctor in there to help you. But treatment is holding it, stop the bleeding. Isn't that what you do? If you have something that's bleeding and it's not stopping, you put pressure on it. Same thing. How is cystic fibrosis identified? And remember, this can happen when no stools are at birth, but they identify it with a sweat test. And it's literally looking for the sodium, the salt contact. As I said, you can lick these kids, and I'm not, please don't ever lick a child unless it's your own, but you would taste real salt. What's included in the plan of care for a child with cystic fibrosis? Well, remember, it has a lot to do with digesting the fats. So you're losing a lot of calories through stools that are foul smelling with cystic fibrosis. So part of it is the dietary, increasing the protein for healing, right? And for calories. You just don't want to do carbs. You want pancreas, right? So you want protein. Taking care of the chest and giving those pancreatic enzymes are good, and you're never going to take a salt shaker away from cystic fibrosis. They're losing the salt through their sweat and their skin. So never low sodium. What is the drug of choice for pharmacological closure of a patent ductus arteriosus? We talked about three of these, so which one is it today? And it's indomethacin. Indomethacin closes it. What it does, it stops the prostaglandin from keeping the PDA open. That's the function of indomethacin, okay? Prostaglandins we give to keep it open when we need it for the oxygen on that infant. Like, instance, transposition of the great artery or tricuspid atresia. No blood's going to the lungs. So indomethacin, closed PDA, it's a medicine. What is not a feature of tetralogy of Fallot? Well, I didn't go over all the features, but tetralogy of Fallot is a pulmonary artery. It's right-sided heart. So when you look at that, what is considered right-sided and what's not? The aortic valve is on the left side, okay? But you're going to see the pulmonary artery is going to be narrowed because when it closes, the right ventricle stretches when it can't get through, and there usually is what we call that VSD, sort of a relief valve. The other thing is sometimes the aorta rides over a little bit, and that's the fourth thing that you would see, but all right-sided stuff. What medication would you hold for an infant that is vomiting and vital signs are 98, 88, 32? And all those medicines can be given to infants, by the way, but absolutely digoxin for sure. What would a child with tetralogy Fallot, why would a child with tetralogy Fallot not gain weight at the normal rate? Why? Tetralogy Fallot, they have tet spells, they get blue spells. What does that do? It's inadequate oxygenation. If you don't have oxygen, you don't have energy. You don't have energy, you're not going to feed, okay? All are examples of a cyanotic heart murmur, except which one? Cyanotic. Actually, there's two here. And it's aortic stenosis. There's still blood coming from the lungs and going to the body. And then there's an opening between the right and left atrium. And still there's oxygen. So those are the two. So the tetralogy and tricuspid are both cyanotic. The other ones are not. What is the most common cyanotic congenital heart defect? I did mention it. And that's tetralogy of Fallot. And we do surgery and treat it sometimes at birth, sometimes later on. Nursing care following a cardiac catheterization. So the big thing is to assess that insertion site for that hematoma. We are going to keep that extremity flat and slowly, maybe, but not to a 45-degree to start with. No. Slowly elevate the head of the bed. Nursing education for a cardiac catheterization include all except remember, they can't ambulate, they're on bed rest, and they can't bend the extremity. Do nothing to make that clot where those insertion sites are to make them bleed again. That's the big goal. Which information is most important when rheumatic fever is suspected? Like, what do you need to know? I see the joints, I see the chorea, I see your sore throat still hurts. What do you need to know? And it's all about, have you had a sore throat recently? And that usually will lead you into rheumatic fever. And then they'll do the ASO titer, anti-streptoliftin titer, and that will show the strep in the blood, which will prove that it's rheumatic fever from strep. Signs of shock in children include all the following except and it's the same thing as adults. So you're going to see hypotension, not hypertension. The rest you'll see also, decreased urinary output, prolonged capillary refill, all of those things are in shock. Which of the following best describes the pathophysiology of Kawasaki disease? So this is that vascularitis, and the most thing we're concerned about is the coronary arteries and the microembolus, and that could cause a myocardial infarction. So that's the big thing with Kawasaki is the coronary arteries. A clinical manifestation of Kawasaki disease it's all of them. Korea is what? That's rheumatic fever. That's not Kawasaki. What is the treatment for Kawasaki disease? It's aspirin to thin the blood for the clots and IVIG to boost the immune system. It's about a month it takes to treat it. Which of the following is the most common cause of shock in infants and children? Infection, sepsis, biggest thing that causes it in children. So we start to see little symptoms, apnea and bradycardias immediately. We're doing septic workups, always. What are the defects associated with tetralogy of Fallot? Remember, it's all right-sided, right? That's how I want you to remember tetralogy. So all the other stuff, it has some left or it's not right. So it is the PA stenosis, pulmonary artery stenosis, VSD, the aorta, and that right ventricle is a little bit swollen and stiff because of extra swelling there. A young child with tetralogy of Fallot may assume which position naturally when having a tetralogy spell? Now you see toddlers that still have not been repaired, and they can have tet spells. And just why, I don't know, but naturally, they just go into this position and they just squat. And it does what? It changes the pressure between the abdominal and chest cavities and it opens it up. It works. Transposition of the great arteries is what? It's the aorta and the pulmonary artery are switched. They have to pick it up, turn around, and put it back on. Yes, they do. It's an extensive surgery. Which of the following is not an intervention indicated for the transposition of the great arteries? Well, this is a big deal. As I said, you have to somehow get blood flowing because they're not, you have systemic and pulmonic, they're not meeting, right? So have the PDA open that patent foraminal valley between those two atriums at birth, and then they do what we call an arterial switch. Oral vasodilators do nothing. Nothing oral with a transposition is going to work, period. It's not. Why is prostaglandins given to a child with transposition of the great arteries? So remember, this is the connection between the pulmonary artery and the aorta and gets oxygenation there. So it's oxygenation and it helps with output. Has nothing to do with infections. Nothing. This is not infections. It's to keep that tube open. It has to do with oxygenation. What is the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? So indomethacin stops that prostaglandins, which will let it close. Remember, that's what mommy's hormone keeps it open during fetal time, right? And then if we want to keep it open, what do we give? Prostaglandins. We just mimic what she has done. Indomethacin says, nope, no more prostaglandins, go away. Where is the patent ductus arteriosus? What does it connect? So remember, this has to do all with oxygenation and getting it to the body. And that helps you remember. It connects the aorta to the pulmonary artery or the or the pulmonary artery to the aorta. It gets oxygen to the body. This heart defect allows blood to pass from the left ventricle to the right ventricle. What is it called? So if there is something that's allowing blood to flow, the septum's not there. It's called a ventricular septal defect. And it says there, left ventricle, right ventricle. It's a VSD. If it was between the atrium, the right atrium, and the left atrium, it'd be an atrial septal defect, okay? What is a sign of digoxin toxicity in infants? So remember, there's a lot of similarities with digoxin, how you administer it, and signs and symptoms you see. But this is an infant. They cannot tell you there's yellow spots. So it is not yellow spots, okay? But they can be gagging and vomiting and their heart rate's low. Remember, digoxin has nothing to do with infection. So it's definitely not that. What is congestive heart failure? Now, usually congestive heart failure in children's due to obstruction. Usually you have adults, and that is the weak part of it, or your older children. Weakness in the heart that makes fluid build up in the lungs. Left-sided congestive heart failure causes the coarctation's pulling that blood back into the left ventricle. And where does it go? It can't go down, so where does it go? Backwards. And signs and symptoms, what would you see? Everything here. Short of breath, coughing, fluid in the lungs. All the left side is getting full. Very good. After a heart transplant, what is the leading reason children die? Rejection, not infection, rejection. The heart is rejected. Almost die. Signs and symptoms of rheumatic fever include A little bit of everything. And remember, all of these things can be turned around when you do a long-term antibiotics. The only thing is heart valve damage that cannot be corrected. That's permanent. A multi. A child's about to have a chest tube removed. What should you do? So we are going to have them more sitting up, not supine. It helps when they pull it out, so sitting up's better. Of course, explain it. Please be honest. Tell them it's going to hurt. Always give pain medicine before you do that. It burns. A child just had abdominal surgery and cannot cough well enough to expectorate secretions. What is your priority? When they can't cough it up, what should you do? Same concept like chest tubes here. They just had abdominal surgery. They can't cough. And the answer is it hurts. Medicate them with pain. Then you can move them, get them out of bed, do incentive spirometry. First of all, pain medicine. Don't forget that. That's a great concept right there. An infant of 3 months has a fever of 103.6. What would you medicate the infant with? Only Tylenol up to 6 months, and then you could add ibuprofen. Put that there because there's always a question about that somehow. A newborn infant is assessed and you find they have very weak lower extremities. What should you do next? What are you suspecting there? Really weak lower extremity pulses. That means blood's not getting there. So, what do you think it could be? Coarctation, right? How do you prove it? For extremity blood pressures, right? That'll show you elevated up top and lower in the bottom. It sort of proves it even before you have an echo. A multi. A critically ill child is on complete bed rest. What can a nurse do to prevent complications? We think that only adults are there long term and complications and decubitus and foot drop and pulmonary, atelectasis is only on adults. It's not. Kids get the same things. So we're going to keep them dry, use that incentive spirometry, use pillows, blankets, help them position, use a draw sheet for shear injuries. Same thing. Same thing. How can oxygen be delivered that is easiest tolerated and accurately monitored for infants? I'm giving you some of last week's stuff in here, okay? It's a reminder of concepts. And that's an oxy hood. Blow by is not accurate at all, okay? But oxy hood is extremely accurate. A multi. What procedure are used to keep the lungs open with a child with cystic fibrosis? Remember, cystic fibrosis is mucus clogged in lungs and the small intestines. And what did I tell you about those lungs? What needs to be done? Morning, noon, and afternoon, right? Morning and evening, right? You've got to do it frequently. Deep breathing, coughing, chest PT, exercise, not PRN ambulation, 3 times a day, whatever it is, just not PRN. They got to keep it moving. A multi. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? And you'll see this question on your NCLEX, and it's a little bit of everything. Remember, anything powder like that, rinse the mouth out because it can harm the teeth, but everything here. What is the cardiac defect when there's no valve between the right atrium and right ventricle? Well, what's the name of the valve on the right side? Tricuspid valve is between the right atrium, right ventricle. A, absent, nothing. That's no valve. Cyanotic heart defect. And last question. When an infant is breathing fast, tires easily, and needs rest periods during feeding, what do you assess? What is going on? Why are they breathing fast? Why are they tiring? Why do they need rest periods? What's happening? What do you need to assess? And it's all about the breath sounds. Yes, it is. Those breath sounds are getting full of secretions. So, number 3, Jen. Good job, Jen. Choop, choop. Number 2, Christina. Good job, Christina. And number 1, you fought for that one, Thomas D. Yes, you did. And PTL and Zen, good job, guys. All right, thank you for holding on for the class. It's really important. Cahoots here, a lot of information, and I think it's a really good test right after that stuff. So everybody, I will be sending you the recording. I'll send you the answer sheet so you have it, but test yourself, okay? It is a good thing. And anybody who don't understand it, you just let me know. Okay? Who wanted to meet me right after class?
Thank you, Ms. Bogart. I appreciate it.
No, you're welcome. All right, Hope, I'm going to sign off and sign back on, okay?
Was we supposed to sign up to meet with you, or could we?
Yeah.